Thanks, everybody. Welcome to Cardiff. So we've done two lecture-based sessions for you, talking about the diagnostic aspect of IVUS in the first one, and then the second one was talking about the theory of stent optimization. So from now on in, we go with recorded cases. So we've actually just recorded this case a couple of hours ago, which was a pretty much ideal case as it turned out. And I'm now going to show you it. So I'm going to share my screen now. Yeah, fantastic. Okay, great. And I'm grateful to my colleague, Dr. Sean Gallagher, who you'll see in a minute, who's our director of cardiology. He does about 600 PCIs a year himself, which is the size of a moderate sized hospital, the volume that he does. And we did it together. And I'm very grateful to the patient and to the staff who allowed us to record this. These are my conflicts of interest, which include being a consultant to Philips. Okay, so just a reminder from the last session. What are we trying to do when we size and optimize stents? We're trying to achieve the best minimum stent area that we can. And in the ultimate study, which was a randomized trial of all comers, so anyone who had PCI, 1,448 of them were randomized to either receive PCI with angiography guidance or PCI with IVUS guidance. The goal was to get a minimum cross-sectional area within the stent of either more than 5 or 90% or more of the distal reference lumen, meaning that the healthy vessel just beyond where the stent lands, if it's 8 millimeters squared, your goal is to make sure the stent is no smaller than 90% of that value, whatever that is, 7.2. You're also trying to find an area to start and stop your stent where you have less than 50% plaque burden, which might sound easy, but actually because of the way area works, a relatively thin crescent can produce 50% plaque burden or more. Afterwards, you're looking for edge dissections when you do your final post-stent optimization run with your IVUS. So those are the goals of therapy, and that's what we're going to show now. Why do we do that? Because what Ultimate showed is that if you just do angio guidance, you have about an 11% target vessel failure rate at 3 years. If you do IVUS guidance, it's about 6.5%. So about a 40% reduction in events, which if it were a drug, I think we'd all be seen as medically negligent if we didn't use that drug, if it had been demonstrated in a randomized all-comer trial to reduce events by 40%. And yet we're not quite there yet with IVUS. So I think part of that is we've got to get more people using it. Okay, so I've got a video here just on prepping the IVUS, and I'll talk over it while we start. We're going to use the Refinity in this live case, and it's a rotational device. It's a 45 megahertz device. It's very low profile. It'll go very easily down a 6 French catheter, and it goes over a wire. It's got a very short monorail segment. So this is me receiving the device into the sterile sleeve, and we want the sterile sleeve to run as far back as we can, as long a length of sterile sleeve over the hub of the rotational IVUS device to make sure that we can move this device up and down the table without desterilizing it. We then start getting the hub of the device in shape. So we take off the sticky thing that overlies the hole. We put the hole of the device where we're going to put the IVUS back into the motorized sled. And then we start prepping the IVUS device. So you can see here, we've got a 3-way tap on an extension. So the 3-way tap goes onto the back of the extension. And then we put a 10 mil syringe Luolock, which comes in the pack on one side as a fill syringe. And then we use our injector 2 mil syringe coaxially with the piece of cable. We fill the 2 mil syringe with the donor 10 mil syringe. And then with the 2 mil syringe, we flush through. So we've got this prepped accordingly, as we see here. And that is going to then refill your prep syringe if you've used it already. But what we've got is a closed system now with a 2 mil syringe having prepped all the way along that line. So all we've got is fluid now in that line. We've got rid of air. Air gets in the way of intravascular ultrasound, so we want rid of that. We then connect up, but before I do that, I'm going to show you how we handle the sled. So you click onto manual and you bring the sled back. Now, one really important thing is you have enough slack in the plastic bag that the hub can go all the way back. If you don't have enough slack, then what happens is as the motorized sled pulls back, it gets caught on the amount of plastic sleeve that you have, and it will time out and say there's a machinery error. But it's not a machinery error, it's just detecting resistance. So when you're prepping it, just make sure that in the cradle of the sled, you have lots of slack in the plastic bag. My assistant here, who is Dan, one of our excellent scrub nurses, he starts flushing through, and I can see that there's resistance, and I realize why. The reason is that the catheter sheath is forwards, and what you want to do when you're prepping is to have the IVUS back within the sheath, so that there's about that much length outside of the sheath. And then when you flush with the 2 mil, give it a tap to make sure there's no air bubbles from the fill syringe. It becomes much easier to flush through, and then we get a good stream through. You then resheath the IVUS. So remember, the rotational IVUS is within a plastic sheath. And then there's a black dot, which is on the base of the IVUS catheter. And that goes in at the base of the arrow there, which I'm going to show you in a second where my finger was. And then we rotate it round and it clicks in. Okay, so that's the device now prepped, and it's taken me 2 minutes. That you then slide the sheath within which the IVUS sits down into the cradle, and you reset the length, and then you press image on and make sure that you're seeing something that looks like an IVUS image. Of course, you're outside of the body, so it won't look like a coronary artery. And after that, you just put it over the wire, put it into the coronary, and press pull back. So it's a pretty simple procedure to prep. As with all things, simplicity comes from practice, and it helps if you've got if you're doing this on a regular basis, so that you and your team are used to prepping the device. Well, you can see there that's real time, although even I think it looks like I've sped it up artificially. I haven't. That's what's doing it in real time. So I'm now going on to the case that we did today. So this is a 64-year-old male. He's a type 2 diabetic, and he's a HGV driver. Now, that's a heavy goods vehicle. That means they have to have very stringent health requirements, including full revascularization. So if they have angina and coronary disease, they have trouble getting their license in order to drive one of these vehicles until they've had revascularization and been proven to then pass an ischemia test afterwards. He has angina on 2 anti-anginals, so he has a conventional indication for PCI, but he also has this occupational reason that he wants revascularization. And we're going to just come along here to 5 minutes where we'll start, and then I'll keep my mouth shut, and we will get on with watching the live case. So I'll just go to the start.
Okay, welcome to Cardiff.
So
I'm Andrew Sharp. I'm one of
case.
the consultant cardiologists here, and I'm here with Sean Gallagher, our Director of Interventional Cardiology, who's our highest volume operator in Cardiff and does a lot of our complex work. Hi, Sean.
Hello.
I'm here with Sarah at the table, and we've got a skilled team here who are going to hopefully explain to you how to use intravascular ultrasound. We've got an interesting case today. We've got a 64-year-old chap who drives a HGV, a heavy goods vehicle, who has angina despite medical therapy on a background of type 2 diabetes and hypertension. He's been discussed at an MDT by the referring team, and having had an angiogram showing some proximal LAD disease, and the team have come to a conclusion that he should have PCI for that. We've now taken the setup shots. So Rachel, if you wouldn't mind just going through the angiogram here.
So if you go forward for us, Rach.
So Sean, do you want to tell us what your setup shots are showing?
So this is a areocranial looking at the LAD diagonal bifurcation. So I think what you can see here is quite significant disease after the diagonal bifurcation that extends a reasonable distance. I think the real challenge in this case is where's normal? Where are we going to land our distal stent? And I suspect we're landing this in the mid to distal LAD where we'll find normal on IVUS. And I think the important part of the history as you presented it was the diabetes. And I think if you're going to stent over long lengths in a diabetic, you have to achieve excellence. I don't think you can do that without IVUS. So if we flick forward one further, so you see a long length of disease in the LAD, keep going forwards. I think the diagonal ostium is spared. There's a wire in the diagonal ostium that you'll see in a moment. That's really there to mark it and protect it. We're not planning to do anything. We're planning to stent the LAD in isolation. One further. And you're seeing a pretty normal looking proximal LAD. So I'm expecting to find a landing zone in the proximal LAD. The one thing I look at with the angiogram is there's probably a little bit of calcium in this. We may be underestimating it, but I think IVUS will have the answer. So strategy-wise, I would start here with an IVUS looking for landing zones and to get an idea of plaque morphology. What are your thoughts, Andrew?
Yeah, I agree. I mean, it looks like the proximal LAD is okay. And so hopefully we're not going to have to go back into the left main here. The distal landing zone is trickier, so I'm not sure where that is. I mean, you can see how the cranial view doesn't really appreciate the kinking and the how in the mid-LAD the vessel dives down frequently into the myocardium and then back out into the distal LAD. So that distal landing zone will be crucial here. This is a slightly longer lesion than I'd expected for this session in the IVUS program, but it's an excellent case on the use of IVUS, and we'll get going, I think.
Yep, agreed.
Okay, so we'll start with upfront imaging. So this catheter is being prepped, and I've just shown you how we prep the catheter already. So now we will get this IVUS down. And that was some nitrates just to make sure we get a true representation of vessel diameters. So we're using the Refinity catheter for this case. It's a 45 megahertz catheter. It's low profile, and it's a motorized pullback, so we can do length measurements. You can't co-register with this. You can only do cross-sectional measurements where you are and co-register by going onto the pedal on the angiogram at the time of the pullback. You need to use the eagle eye for co-registration, but we'll come to co-registration in later segments of this online series. Okay, great. So we're down at that distal septal there, maybe a little further.
It's going to go on a touch more.
Yeah.
I'll just take an angiogram there,
Yeah.
just as a setup so we know where we are.
Okay, great.
Okay, good.
Okay, good. So we're going to turn the image on. We've just got a little bit of artifact there, so we'll just sort that out.
There we are.
And there we are. Okay, great. So we know where we are on the angiogram image. If you're doing a motorized pullback, you've got to co-register it yourself. So we're going to stay on fluoro during the pullback so we can work out where we are through, and then we'll stop and Sean and I will talk through what we find. This is set at 0.5 millimeter a second, so it'll be quite a long pullback here. But we're probably looking at about 30, 40 seconds. I think in the grand scheme of things, for doing a long proximal LAD in a diabetic, you can afford that sort of detail and data. Okay, so what you're seeing at 12 o'clock there is the wire artifact. So if you're a single wire case, which we're not here, but we are where the catheter is within the LAD, you will always see a wire artifact with a rotational device. With a solid state catheter like the eagle eye, you will not see that wire artifact unless you've got a second wire in place. So you can see a branch coming in there down at 5, 6 o'clock. And as we come up towards the prox LAD, the diagonal wire will come in eventually. It's actually a better vessel than I expected.
Absolutely.
So in real time, you can always get an estimate. So there's more calcium there than I expected.
Agreed.
So that's the severe stenosis in between the first and second septal. So we might need to prepare that. You can see some NURD there, non-uniform rotational distortion at 3 o'clock. That happens with rotational devices. It's just where the catheter is getting slightly restricted in its rotation within the IVUS sheath. Ways to avoid that are to keep your O-ring open, to keep the catheter straight and avoid kinking it during the prep. But sometimes it's unavoidable in a rotational device. You can post-process it out, but it isn't post-processed out with this software. And then we're coming back towards the diagonal now, so we're going to see a second wire come in any moment.
Second wire's in now.
Yeah, we're seeing one there going towards 1 o'clock. It's hidden by the NURD. And then here's our prox LAD, which as expected is a good landing zone, pretty healthy looking vessel. We'll come back into left main, and maybe we've already crossed into left main.
Yeah,
we crossed into left main. So, and we see the aorta coming in there, and then we're back in the guide catheter. Okay, great. So let's take this out and we'll have a look at those images and decide what we're going to do.
I think IVUS was very helpful there.
Yeah.
I think actually the vessel is much better distally.
Yeah.
than I expected.
And worse within the body of the lesion
Agreed.
than I expected.
More calcium than I expected.
Yeah.
So it's going to change the way we approach this completely.
Yeah. Or anything like that. So we have the intrasight system here, which allows us to control it at the table side. So what I can do is drag the IVUS image back. And now if I drag down myself on the touch screen, we can see this pretty beyond where we're going to stent. We've got a very healthy architecture here. If I wanted to measure the distal LAD, I can just do it with my finger on the touchpad, and then you can correct any errors in the estimation of the computer. So it's 2.5 millimeters distally, which I think we could have guessed from the angiogram. The more interesting thing is, Sean and I were concerned about what happens in the mid-LAD. Now, there is a bit of disease here. So you can see here, we've got a 12 o'clock wire artifact going north there, and you can see how the wire causes dropout in a small arc at 12 o'clock on the image beyond the vessel here and here. Okay, so as we carry on coming back, we'll see that there's also a calcified area here. It's superficial calcium causing dropout behind it here to here. Now it's less than 90 degrees, so this would be easily modifiable with a standard balloon. It's not really what we call a nodule, it's just calcified atheroma. It's not projecting out into the vessel. It's just this calcified plaque within which there's superficial calcification causing dropout behind it in the areas that I've marked there. Now we're coming more proximal, and you can see there's certainly a bit of disease here. So we've got some fibrosis around here, but you can see behind it, so we're not getting much dropout. So that's how we know the white material is fibrotic rather than calcified. We've again got our wire artifact coming up there, but on the whole, we've seen a lot worse. We're coming back to here. There's a potential landing zone there. So suddenly the vessel looks beautiful here. So let's imagine this was our landing zone. We haven't decided yet. We're going to select our media. So we're looking for the jet black circle inside the bright white adventitia, and it's huge. At this point in the mid-LAD, it's 3.5. And I just wonder if that's that ectatic segment shown in the middle there, because it's palpably bigger on IVUS here than anywhere a bit proximal to it. And then we've got this, so I think it is that area.
Yeah.
So this is the surprise. So what do you think? I mean, this is not what we expected to find.
Well, I think we've got a tight lesion. There's a bit more calcium in this than I ever thought.
Yeah.
But actually, most of it's intimal calcification here in one quadrant. I think as you come further back, there's a bit more calcium.
So we got quite a lot of dropout, haven't we?
Yeah.
So at this point here, so if I just show there, this is a very good example of 3-quadrant calcification. So we've got calcification from there, and we see nothing round the arc from 2 o'clock all the way around to 10 o'clock. Now we do get a little bit of penetration here, so it's quite thin calcium from 9 o'clock round to 11, because we are getting a little bit through into the adventitia, but we're losing a bit of resolution. The absolute calcification is more like there. So we're going from 2 o'clock round to 9 o'clock. So we've got a 2 and a bit arcs of calcium at that point, and then we've got some thin fibrocalcific disease from 9 round to 2 that's allowing some tissue penetration. So that's usually a signal that it will give with a balloon. So when you've got 2 arcs, what's your thoughts?
Here,
Yeah.
I mean, I'm looking at this. I think this is going to go up with a balloon. So I'm going to take a Scoreflex balloon here.
Yeah.
And I've sized that to the distal vessel. So I've just asked for a 3.5 scoring balloon.
Great.
And then we'll re-IVUS afterwards and see where we are.
Yeah.
I think most of this is intimal calcification.
Yeah.
And I'm pretty hopeful that this will go up.
Yep. And then in terms of sizing, we've sized our distal reference as
Yep.
being 3.7 by 3.9, if I remember.
Yeah.
We look proximal to the lesion to get a signal that that's right. And we got 3. It's a little oversized, that, but it's about 3.5 there. So we're not going to go to extremely high pressure with this scoring balloon, but it's about 3.5 by 4. And then as we come more proximally, again, you've got this 2 quadrants of calcium. So here, round to here. So from 7 o'clock round to 2 o'clock, we've got complete dropout from superficial calcium, and then we've got a little bit of signal getting through on the other side. But that other side's fibrotic as well. It's a bright white signal. So that's going to be difficult to release, and that's another good candidate for a scoring balloon. So let's get going. Okay, so tell us about the Scoreflex, Sean, for people who are watching who don't use it.
So what we've got with the Scoreflex is we've got a semi-compliant balloon with a very, very short monorail segment. On the balloon, there is a scoring filament, and the short monorail segment means that the wire sits outside the balloon. So you have two areas. You have the filament outside the balloon and the wire where you achieve forced focused angioplasty.
Yeah.
So the balloon is driving the wire into the wall of the vessel, and we get more dilatation force there. So just going up on the balloon now.
And it's
That's up.
our proximal landing zone's 4.1 by 4.8, which fits with the angiogram really. A 4.5 will serve. You've done the mid LED as well, or?
I'm not sure we're quite far enough down. I just wanted to see now.
Yeah.
Yeah, I just need to go on a little bit more.
Yep.
Can I just come back? Little test there, because I
Just
don't want to commit too far down the vessel.
I want to go to
That's
that
fine. That's fine.
ectatic segment, don't
Yeah.
we? Going up.
Good.
So I'm
Perfect.
just at 10,
And
and that's
gone up
released
beautifully.
nicely. Now, it'd be lovely to see if that's cracked, wouldn't it, on the IVUS? So
Yeah.
shall we do that?
I think that's really good practice now when you're dealing with any kind of calcium. IVUS, I think when we started using it, was there to size stents, look at morphology, but actually I use IVUS to guide every step of the procedure.
Yep.
I do a lot less angiograms and a lot more IVUS.
Okay, great. So let's have that back. So I always just give it another little injection. Just tap, make sure your bubbles are at the top. Whoops, that was unexpected. Okay, we're going to have to refill that if you don't mind. You got some coming out there?
Yeah, that's great.
Great. Thank you. Cheers. Yeah, please, yeah.
Please. Just follow for me.
Okay.
Okay. Just on a touch more.
Yeah.
About there is where we're looking.
Okay, so our image is on. We're
there.
pretty distal there.
Not sure we're quite as distal as you think.
And we threw that ectatic segment. What is it? I call it ectatic. It's actually the normal vessel.
That's where we are.
Yeah.
Yep, on we go.
Okay, great. So let's do the pullback. So this is the LAD after we've prepped it. You can see there's still that small single arc of calcium there.
And there's that little aneurysmal segment that you see
Yeah.
in the angiogram, and then we come in to pretty normal vessel just proximal to that.
Yeah. So I'll bookmark that to measure. And then we're coming back into areas where we had quite tight, almost napkin-like disease, albeit only 2 quadrants were calcium, 2 quadrants were fibrosis. That looks pretty good now. See how much more resolution we're getting out in the adventitia and beyond because we've released all the segments that were obstructing the IVUS beam. So the IVUS is now able to get through and beside the calcium because we've cracked it. Looks almost like there's nothing left, doesn't it? No disease left.
And my result.
Yeah. Well, we have used drug-eluting balloons before in this scenario, but there you go. You see there's a dissection down there at 12 o'clock, at 6 o'clock. And here we've got the prep segment. You can see just how much more image we're getting from the full 360-degree view, and that's because we've created gaps in the calcium for the signal to get through. And then we're coming back towards proximal. It looks a completely different vessel now, which is the goal of prep. And then we're coming back now, Prox LAD. There's the 2 wires. ACT's ready. Do you want to just get a quick ACT? Once we get this out, actually, otherwise it'll suck air in. And then we're back into the left main. So in the interest of time, we'll stop there. Yep. This has just got caught here.
Okay.
Yeah, just trying to untangle those. Thank you for that flush, if you wouldn't mind. Yep, sure, yeah.
Good. Can I have an ACT syringe?
Okay, great.
I've got it at this end. Sorry.
So I'll just have a look at this IVUS run there. There's our distal vessel again, which had a single arc of calcium. Here is what we're calling an ectatic segment, but it's actually a healthy segment. And then we come back in, and that was where we had that lesion. And you can see how much more we're seeing now. It's nicely released. And then as we come back to this segment here, which will be within the body of the stent, we're at 3.25 there as an average. And then as we come back, this is a segment that's really had quite extensive preparation. There's maybe a bit of negative remodeling in this segment. So 3.25 again within this segment here. And obviously there is this debate about what you do within negatively remodeled segments of vessels. You know, it used to be a bit bigger, but now it's a little smaller than the distal reference. And so we're always a little cautious about how aggressive we are within negatively remodeled segments. And then it goes up to 3.5 in the body of the lesion more proximally. And then we're coming back here for our landing zone, which should be 4.5 given that it was earlier. And it's around that.
Yeah, so what in terms of length, what are you thinking?
Yeah, so let's say we're starting here as our proximal reference. And our distal reference is about 3. That second run, we haven't gone far enough. There, that's our landing zone.
Yeah, that's about right.
So, so yeah, 30. So our landing zone is there distally. This is the ectatic segment. 3.5 set as reference. And then proximally, let's get rid of that. Done.
Got
There.
38 stent.
Yeah.
3.
Okay, so we've got, when we get our landing zones right, it's 36 to 38. So we'll take a 3 by 38, bearing in mind that within the body of the lesion, there's some negative remodeling and the vessel's only 3.25 at that point. We can always make a 3 bigger.
Exactly. And we're looking at 4.5 roughly in the proximal vessel, and we can take this stent platform to 4.5, 4.8.
Yep.
So I'm comfortable with it being 3. I think if it was bigger proximally, I would do this in 2 stents, and I would go 3 distally, 3.5 proximally, and blow it up.
Yep. I mean, this is a Zions, right? So it goes to 4.25 proximally
it'll go a bit bigger
on
than
message, but you can make it bigger than that.
Yeah.
Thank you. Okay, let's turn that. Thank you.
Okay, just come PA caudal for me, please.
So I think it will go to that appearance of the ectatic segment, won't it?
Agreed.
Just. So one of the difficulties with this, Sean, is how we pot the proximal segment, because it's such a short segment
Send
of
up, please, Rach.
prox LED.
Yes, no.
And we'll just
go.
picture that.
Good, yeah. Good.
Okay, so good. We don't have to be true osteal.
Okay.
We've seen that it's
Let's
healthy.
come areocranial, please.
That whole segment of prox LED is healthy, so we don't have to land at the ostium.
Good.
Just needs a millimetre forward, do you think?
No, I think on the IVUS we were pretty sure that we had that area there where it was slightly ectatic, and actually we had relatively normal vessel proximal. So I'm okay coming a touch more proximal.
And the Zions is mid marker.
Mid marker.
So if we're looking at that distal mid marker, we've got that ectatic segment. What's your aim for the distal edge of the stent relationship to that
Well, I think
ectatic segment?
if we're looking at the IVUS, I'm not too worried about that ectatic segment, because the IVUS was telling us we had relatively normal vessel proximal to it.
Yep.
So I'm okay with that.
You just stretch a normal bit.
Yeah, I think it will look fine.
Yep.
Yes, there's going to be an ectatic bit. There's nothing we can do about that. So, okay, I'm happy there.
Yep, so we're going to go up. Going up, and this is a 3, so we can afford to inflate.
I would give it, so I could sort of go 18.
18, yep. So obviously with these semi-compliant stent balloons, they elongate if we go too high, but
that's good.
You can actually see where it is there. That's 18.
Can we have a 325/20 NC, 35/15 NC, and then a 408?
So I think it's reasonable to post-dilate on the basis of your pre-IVUS, but you've always got to check afterwards. We might have to go back with bigger balloons because it could look different once we've released
agreed.
this.
Agreed.
Thank you, sir. And check you're okay.
Yeah,
and we look fine as predicted.
Yep, great.
Yeah.
And then if we have a 35/20 or a 35/15, something like that. And then a short 4, ideally an 8.
So this is long stent 48. 38, sorry. So there's no question that our distal reference is not the same, giving us the same information for the distal part of the stent as the proximal, because we're going across into a 4.25, 4.5 millimeter vessel. So there's, please. So there's a couple of ways we can handle this. We can segment the stent into 2 and just treat them almost as 2 independent stents and try and get expansion more than 90% of the distal reference of each segment. Or we can segment it here, which is slightly more logical, into the 2 parts of the vessel. So you can see after the diagonal comes off, the vessel steps down in size from about 4.5 down to 3.25, 3.5. So we could segment it according to the prox LAD reference where the diagonal comes off. So we'll have a look at that afterwards.
I think that's really what we're doing though, Andrew, aren't we? We're segmenting distal to the diagonal into 2.
Yeah.
But then we're treating the vessel proximal to the diagonal separately.
Yeah.
Good. That's fine.
Yeah, great. Up you go.
It's 14.
Yeah. And down.
I'm just going to go a bit harder there.
Yeah.
16 there.
16. 16.
Good. And down.
Down from 16. Okay, so what's your next balloon? 3.5?
3.5.
Yep.
We're just distal to the bifurcation.
Thank you. And there's your wire. That's to be said, I would have thought it would have been longer than a 38, just looking at the angiogram.
Yeah, no, I agragree. I
said 48 just because my brain was looking at the angiogram and thinking
it
48.
looks longer, but, well, it's not, is it?
No,
it's
fascinating. Have you got the prep syringe there? There you go. I'll give that to you and I'll do it.
I think it's interesting that, I think we have this thought process that IVUS makes cases take longer. I think it's made it quicker. I think we have a thought process that IVUS makes us do more, and actually it's making us do less.
Indeed. Indeed, we're happier with our landing zones there.
Yeah. So up you go there. 10 or 12 is probably enough.
12? Yeah.
Good, and down.
Yeah. Down from 12.
Now we're going to come back across the bifurcation.
So you'll recall that in the distal severe lesion, we had negative remodeling and the vessel diameter was only 16.
Yeah, sounds good.
16. Down from 16. The media to media within the body of the severe section was only 3.25, even though the distal landing zone was 3.5. So in those negative remodeled segments, just be a little bit cautious about how far you push it. I released some data at the ESC in 2009 showing that in cases that rupture after IVUS, they're more likely to be within remodeled segments like this, negative remodeled segments. In fact, 5 out of the 6 where we found rupture after an IVUS was in a negative remodeled segment. So remember, our goal is to get an area 90% or more of the distal reference. We don't have to get 100 or 110.
Can we have the 4.0, please?
Yeah. So now we've got this challenge that it's a very short segment. So we want to avoid ballooning the ostium of the LAD where it's not stented. But equally, we've got to be a little cautious about going beyond into the mid-LAD. Now, the fact that there's a septal immediately after the diagonal gives us a bit of leeway, because that confluence of a bifurcation is always more forgiving than a smaller segment on its own.
Forward. Forward again. Egg. Good little test there. For
Yeah. And do we want to check in caudal?
Yeah, I think we should check in caudal.
Yeah, Fleur, save that and come to caudal, please. And then if you could cone a mag on it, just so we get a lot of resolution. So
Centre up, boys.
Yeah, you're a bit,
Probably a little
too
out,
proximal then.
Yeah, okay. No, you're good. No,
Yeah, so we're a bit too proximal there.
that's okay. Okay. I think we accept that.
Yeah, that's
It
good.
is what it is.
Yep, that's fine. We're in the stent now. Going up, so I'll be relatively cautious here. So 8, let me know how you want to go.
And 12.
12.
And down.
And down. So down from 12, that's with the 4. Okay,
And
so
a little puff for me.
yeah,
Lovely. Good.
quick check,
Let's go
make sure we're all right.
cranial, please.
And then we'll re-IVUS. Yep. I'll give you that, Sarah. Do you want some nitrate? This will make it look nice. So you're happy your diagonal's got Timmy 3 flow, so
Yep.
that's out. I mean, it was a healthy ostium, so
Yeah, it was fine.
if we had, if this was disease diagonal, maybe we'd have IVUS the diagonal as well.
We saw on the flyby that
that
it looked
looked
fine
okay.
at the os, so I was pretty comfortable.
Yeah.
Good. And if we have the IVUS catheter back now, please.
Yep, sure. And that's the other thing about IVUS, is it can reduce contrast even if you're not trying to do a zero contrast procedure. Because, you know, why do you want to take 4 different views to see if there's a dissection at the exit when we're about to find out properly if there's a problem at the exit?
Just a touch more.
So image on. We're at 0.5 millimeter a second. Okay, we've got nice landings on there. Do you just want to fluoro save that? Oh, well, we got it
All
there.
right, we got it.
Okay, great. So we're coming back now. There is a little bit of fibrotic disease there distally, but it's certainly not flow limiting. And then as we're coming back into this ledge of the stent, we're getting ready to press bookmark so we can easily find our stent edge and just double check for any edge problems. But at the moment, we've just got less than 1 arc of calcium, and otherwise a pretty healthy looking vessel. There's that ectatic segment that we aim to land our stent in, and we've landed it perfectly. This is pretty well expanded. Maybe go a touch higher there, but we'll have to see what the area is before we decide on that. I'll bookmark that for a look later on. But all in all, it's looking okay so far.
It's looking pretty good.
And of course, when you start out with IVUS, that's a little bit small there, so
Agreed.
we might need to do something with that.
Agreed.
So what we need is that maybe that 325 at higher pressure. What do you think? 3 or 325 at higher pressure?
I would
We'll
agree.
measure it in a minute.
325 I'm happy with.
So if you want to make an underexpanded segment bigger, you don't need more diameter, you need more pressure. So I've seen people reach for bigger balloons when they see an underexpanded segment. What you need is bigger pressure. And then we're coming back proximally. It's a little undercooked there. Only a little though. The area is not bad.
Coming
There's
across the diagonal.
Yep. And that was the septal and then the diagonal.
Yeah,
and so
okay.
here we're in the prox LAD. There's a touch of malapposition down there at 5 o'clock, but nothing too bad. And then there's another little bit of 10 o'clock there. You can tell because you start to get this reverberation artifact behind the stent struts. But all in all, it's pretty good.
All in all, it's pretty good. Yeah,
Our proximal landing zone is okay.
So if we take the 325 NC back, can we have
We'll
a
stop that.
375 long NC? And do we have a 456? And then a 4.5 by 6, please.
Yeah. So if we're putting that proximal stent on the wall, we don't need high pressure. We just need to, in that case, go more diameter because it's not an under-expanded stent. In the sense that it's being restricted by the lesion. It's just that the balloon we've used isn't big enough to put the stent on the wall.
Yes, please.
Yeah. So this is the 3.25 that we used earlier. And we'll just use this just to try and inflate that small segment of under expansion there, which I'll demonstrate in a second once we've got this down.
Just go back a picture for me, Rach. What?
8. Okay. We don't have a 6 anywhere.
Good.
Yes, please. Yeah, 6 would be better. So as I measure the area here, you can see it's not quite right there. Okay, so at the smallest bit of the stent, it was 2.5 by 2.9. So that's why we've taken the 3.25 back and we're going to higher pressure. What are you at now, Sean?
22.
22. So it's not that we need larger diameter. We've taken 3.25 above either of these measurements. It was 2.5 in one plane and 2.9 in the other. What we need is higher pressure to release it to the diameter of the balloon. So hopefully we've done that now. As mentioned, you do have to be a little cautious. 3.25 at 22 will go to about 3.4, 3.45 millimeters, which is a little beyond the media to media diameter we measured at that point at the beginning. Now, the distal reference will accommodate that, so hopefully this will. And we had no choice. We've got to blow it up bigger. Because that 5.9 area is not going to be 90% of the distal reference.
Okay, that's lovely. Have we got the 375? Okay.
Yeah.
Okay.
Okay,
it is
we'll
what it
take
is.
that.
It is what it is.
Yep. And we want the 375 first. Yep. Okay, great. I'll take that.
Okay. Oop. Forward. Neg.
Right, I'm just going to get our landing zone area now. We've post-dilated it. So our landing zone area, admittedly it's an ectatic segment, so we've got to be a little skeptical of this, is 10 here. And so the second rule from Ultimate was get it more than 5 millimeters squared. So you can see here, the vessel is 8 within the stented segment distally. And if I do another measurement within the stent, so the distal edge of our stent is around, looks like I'm cheating there, but I am just a little bit underestimating there. So 5.1 at the distal edge of our stent. So we've met the second rule of Ultimate for stent optimization. Has to be over 5 or 90% of the distal reference. So we are meeting that here.
Just go there. Just go to 10 there.
10.
That's fine. And down.
Yeah, and down.
And then let's have that 4.5.
Okay, and then there's the 4.5. So we do have to be a little cautious here because the nose of this balloon is either going to be too proximal to the stent or it's going to be beyond the diagonal. But that septal that sits just beyond the diagonal will give us a bit of leeway here.
Yeah, I think that's a really important point. That you've got a little bit more space than you think.
Yeah.
in the kind of confluence of the bifurcation.
Yep.
Right, neg for me.
And so again, we want to avoid, I mean, although the ostium of LAD was healthy, balloon injury at relatively low pressure is not likely to do much harm. We want to stay within the body of the stent. We don't have a 6mm length balloon in this diameter, so we've just got to make a best called judgment on whether we go slightly beyond the diagonal and accept that the septal is forgiving, or whether we go proximal to the stent and risk ballooning the LAD, or we take a different balloon. So this is perfect. It's right back at the ostium of the stent. We're not going to injure the proximal LAD before the stent. And Sean's going to go to relatively low pressure.
I kept it at 10, I think.
At 10. So I'm not sure our inflators know how to go only to 10. But in this case, we are going to take quite a low pressure inflation. And then you get the balloon into the catheter and just check you're okay. Just close your O-ring. Let's make sure we're okay. And we're okay. So we'll give you that. Okay, great. So IVUS again. And then hopefully we're done.
Areocranial again, please, Rach. Big flush for me.
Yeah. Okay, that's a good flip through. Yeah, so that tells you something, doesn't it?
No,
So,
it does, we've got wire bias.
well, we'll see. So it got, the IVUS just got caught on the top edge of the stent on the way in. It may just be that the wire was just up against the roof, or it may be that there's a little bit of malposition still at the roof, so we'll see. So our exit is perfect, and we've got a bigger stent there. I think we can appreciate that this is much better expanded. And we've got uniform expansion. It's a nice round stent because we've gone to higher pressures. At the moment, I'm extremely pleased with this. There's that segment that didn't quite go up, so we'll measure that in a minute. We need it more than 5 or more than 90%, so 5 is going to be our go-to measure. Those were the parameters in Ultimate that showed a 40% event reduction with the routine use of IVUS. Here it looks beautiful. And of course, acute malposition is not a predictor of stent failure. There's some very weak OCT data. There's very little IVUS data. It's expansion that's the issue. And we've got a very large, nicely expanded stent there. And then we're coming back into Prox LAD now. And there was, just to see at 5 o'clock, there's just a little bit of malapposition there. That might have been where it got caught or not. But either way, you can't make that much better. And it's not a predictor of stent failure or a problem.
That's pretty good, isn't it?
Yeah, we're just coming back out. Yeah, there's just a little bit of something there. I'll look at again in a minute.
I think it's just landed in plaque.
Yeah. Okay, I'll have a look at that in a minute. But in terms of expansion, we're looking pretty good, apart from that one area where we took the 3.25 to 22. So we're going to have a good look at that now. So I'll drag it to here. That's where it was. So it was just about 5.1. And it's 7.3. So that was well worth taking that bigger balloon. There's one thing that caught my eye back in the Prox LAD. So as we came back, yeah, you see there's some malapposition at 9 o'clock there. But it's fine. It's very mild there. As soon as I let go, it moves. But this is no problem. This massive area. So we're looking always at our landing zones, make sure that there's not more than 50% plaque burden. So here's our distal landing zone, which is fine. There's not 50% plaque burden there. And then stent comes in. We look at the proximal edge. And we're looking for plaque burden here. And there's not 50% plaque burden there. If I measured it, I'm sure I'll tell you. And then we're looking for dissections. and there's no dissection there. What we're seeing up at the 10 o'clock is the minor malapposition I talked about. So I'll just draw that here. Right here, there's minor malapposition. Now the EA PCI guidelines say if you've got more than 400 microns of malapposition, you might want to think about doing something to it, but on greater than 0.3, then, but in this case, we're done.
Oh, we're done.
We just need to
15 normal range.
We just need to do an angiogram, make sure there's no wire mischief, but I'm pretty hopeful this is going to look nice.
Open up fully.
Nice. So you can see we've still got a little bit of eccentric plaque there. I think if we go to another view, the LED will look.
PA cranial, please. Yeah, just away from me a touch. Good. Okay. And PA caudal, please.
And so you can see there's that ectatic. There's actually a tiny branch there. That's so the ectatic appearance is a blocked old small diagonal, isn't it? So that's the stump of the ostium of diagonal that makes it look like there's such an ectatic segment distally, which explains why it looks so healthy at that apparently ectatic segment. What we're seeing on the angiogram is the stump of the diagonal occlusion, which has been gone for a long time. Okay, Sean, that's beautiful. Summing up from your point of view?
I think it's a great step.
Yeah.
But when I looked at the angiograms, I would have been looking to stent much further. Actually, we've kept our stent relatively short. I didn't expect it to be quite as much calcium. It would have been very, very easy to put a longer underexpanded stent into this vessel, and that would have led to poor outcomes. So I think we've done the best job we can in a diabetic who's going to have a high stent failure rate, so we have to do the best job we can.
And you see in this view how shortening the stent has made such a difference.
Yep.
We've avoided that kink where it goes down into the myocardium. It's a little hazy in the intramyocardial segment, which we've seen was fibrotic disease on the IVUS. So the chances of this stent lasting, if it goes round that bend and into that much smaller segment, are lower. I think it's a great example. So how long have we been operating for? 35 minutes. And we've done 4 IVUS runs, whatever we've done. So this business of you've no time to do IVUS, I think we've just demonstrated that that's not the case. Okay, thanks everybody. We'll take questions once we stop this video. And this is the first of 8 live cases that we'll do that will get progressively more complex. Thanks to everyone in the lab. Thanks everybody.
We saw a lovely example, I think, of a long lesion being having the native vessel assessed. We thought we weren't going to need anything sophisticated to prep the vessel, so we actually had an ordinary semi-compliant balloon out on the trolley, a 2.5 by 30, to pre-dilate it. And when we saw on the IVUS that there was 2 arcs of calcium, and on the opposite side was fibrotic material, that we thought it might struggle to go up with an ordinary balloon. So we took a sculpting balloon and released it with the blades of that, or with the wire of that. We then found our landing zone. And what was interesting is the landing zone looked very healthy on the LED IVUS, and yet the angiogram, it made it look like it was ectatic and diseased. And so we didn't really work that out until the end of the procedure as to why that was, because there was insufficient flow down the LED to see that there was a very small diagonal that had a chronic occlusion that we could now see backfilled up towards that stump. And so it wasn't ectasia at all. It was a healthy segment with a little outpouching from it that was representative of the stump of the CTO of a 2 millimeter third diagonal. We found our proximal landing zone. I think that would have been easy on angio as well. I think IVUS didn't have that much there other than give us the size, which was 4.2 to 4.5, depending on where you cut it. We then, once we'd released it, we checked that it was released. And although sometimes, even on high resolution IVUS with 45 megahertz and beyond, sometimes it's difficult to actually see the cuts, which you sometimes see with OCT. What you saw was a much greater field of view behind the vessel. And so we knew by seeing that we'd created cracks in the calcified segments, because we could see much more of the surround of the vessel. And the only way that happens is if you crack the plates of the calcium, pushed it aside, and then the IVUS beam can get through in between the cracks, and you can see more of the peripheral field of view. We then took our stent. Now, our distal landing zone was 3.5 to 3.7, depending on where you measured it. Our proximal landing zone was 4.2 to 4.5. So ordinarily would have taken a 3.5 there, and we measured the length at 36, so we took a 38. So why did we take a 3 instead of a 3.5? It was because within the two tightest napkin segments, we measured the media at 3.2 at that point. And in 2009, when I was in Milan, I looked at the database of about 40,000 cases. And one of the whole points of using IVUS up front is to make sure that you don't then rupture the vessel by taking balloons that are too big. And I found 6 ruptures. And of those 6, 5 of them had 3 arcs of calcium or more with negative remodeling. And what had happened was the operator had sized the balloons and the stents on the distal and proximal reference, which is what we tell you to do. But in the middle, in between that, the vessel had shrunken down because it was heavily diseased with calcium and fibrosis. And so what happened was the rupture had occurred as we were trying to restore the old diameter of the vessel. Now, remember, that's incredibly rare. That's 6 cases out of 40,000. So, we're doing this all the time. If we look at an angiogram, what we're doing is we're visually estimating the reference proximally, visually estimate distally. We've no idea what's in between because it's diseased. So when we put stents in, we get away with this all the time. So you shouldn't be terrified of negative remodel segments. But having seen that in two segments, we took a 3. We were confident that it would go up to 4.25 from the engineers, which usually means it's 4.5 for the real world. And we were able to use one single stent, post-dilate with a 3.25 to 22 atmospheres distally, which then sized the vessel for the distal landing zone of 3.5. And then we took a 3.75 in the sort of mid to proximal segment. And then we took a 4 millimeter balloon for the proximal edge, but actually it wasn't enough. We still had malapposition. And so we took a 4.5. You don't need high pressure in that situation. You need diameter for malapposition. You need high pressure for under expansion within a calcified segment. You need diameter for malapposition. And we just took a 4.5 up to relatively low pressure proximally in order to fully oppose the stent. And we'd used a provisional approach to the diagonal, which was healthy, and it was fine. So we just removed that wire and didn't recross it. It was only a modest diagonal with excellent flow and no angiographic carinal shift. So that's a relatively short lesion of 36 millimeters long. So the IVUS XPL trial showed that with a 28 millimeter or more long lesion, IVUS guidance can reduce the risk of events. And I'm hopeful that we've just demonstrated how that can be the case, because we used exactly the right length of stent. We avoided excessive treatment of what looks angiographically like a mid to distal LAD that might be diseased, but actually it wasn't that bad. We've avoided going around a sharp bend in the LAD. And we've got the biggest diameter of the stent that we could safely get. We were 5.1 when we thought we'd done enough. We re-IVUSed, saw that we weren't big enough, fixed it, and we were above 7 millimeters squared after that. So the chances of stent failure drop off dramatically as your cross-sectional area minimum gets above 5. So I'm pretty hopeful for this chap. I think he's going to get a good result from that. Right, I wasn't able to read the chat while the video was on because it kept stopping the video. So sorry about that. I'll have a little look. So when a cutting balloon, so we did use a scoring balloon, cutting balloon, sculpting balloon. So we would have been happy. I'd have been happy using any plaque modification technology there. You could argue just take an NC balloon and blow it up, but I think the key was we didn't just use a simple semi-compliant balloon when we saw that there's 2 arcs of calcium on one side and fibrotic disease on the other. We need something to modify it. If there's any other questions, feel free to drop them in the chat. Thank you for the positive comments, and I'm sorry about the technical glitches, but we got there in the end. What I didn't tell you, by the way, was that before that case, we had STEMIs in the morning. So we should have recorded that case about 4 or 5 hours earlier. And in fact, we finished it with about half an hour to spare because of the STEMIs. And then as soon as we started the case, they called another STEMI on the way in. So we did that whole case with a STEMI on the way. So we were going a little bit quickly in the recording, but hopefully it was easy to follow. It's STEMI Day in South Wales. So if there's no more questions, then what I'll do is I'll sign off, given that we're a little bit over time already. Thank you very much for coming. The next, we've got another 7 of these sessions to come, and we'll gradually build up a library. So I'd encourage you to, certainly with this one, once we edit it down and get rid of the glitches, then when you come back to the website, you'll be able to watch it once more. And hopefully if you watch it a second time, you'll start to get into the rhythm of it. and we'll gradually take you through how we handle all the different lesions here in Cardiff over the course of this case series once a month, and we'll flag up when those dates are going to be in good time. Keep an eye on my Twitter feed if you want to know when the next one's going to be. All right, thank you to everyone. Thanks to Philips for sponsoring, and thanks to the organisers for getting us over the line. And I'll see you in about a month, where we'll hopefully have another interesting case. Thanks, everybody.